Order, order. Luke Taylor to move the motion.
I beg to move that this House has considered chronic urinary tract infections. Thank you, Sir Desmond, for letting me hold this important debate. It's a pleasure to serve under your chairship, as always. Today I rise to speak about a horrific condition that has been ignored for much too long. For thousands of Britons, chronic UTIs turn ordinary lives into living nightmares. The pain and permanence of this illness has left thousands suffering on a daily basis. Having heard many of their stories, it is clear to me that what they're living through is nothing short of torture. But this speech is not just about a medical condition. It's about a scandal that highlights the systemic failure to take women's pain seriously in this country. Over the last few months, a brave community of patients have shared their stories with me. Stories of trauma, of suffering, of desperation. I've been utterly heartbroken by what I've been told. The cruelty of this condition is matched only by the cold indifference its sufferers have faced from our healthcare system. It's a national disgrace that thousands of chronic UTI sufferers have been so profoundly let down by modern medicine. Absolutely. Thank you.
I'd like to congratulate the member for securing this really important debate. As a physiotherapist, I understand with chronic UTIs, there are a number of patients that will say to me this will increase their urgency, then leading to incontinence, and the stigma behind incontinence is absolutely disgraceful. And does he understand and agree with me that it's not just a wider strategy that we need when it comes to, looking at UTIs, but looking at the side effects such as people falling, number of fractures that happen because people are rushing to go to the toilet, and how important it is that we're looking at this as a wider strategy instead of just thinking it's a single issue?
Absolutely. I thank the honourable member for her intervention in raising these related issues, which are so important to consider as well. I think I'll come on to talk about the wider challenge of women's health being treated without the importance that it requires. And I understand she's attempting to bring a debate on a similar subject, so I offer her my best of luck in that endeavour. So many of us have already heard of this illness and heard people's stories. I first learned about this illness through my constituent Phoebe. Phoebe has lived with a chronic UTI since she was 3 years old. Now in her mid-20s, she's become a tireless advocate for others suffering in silence. She shows remarkable perseverance and strength, even when the pain she lives with is beyond anything I can describe. Phoebe is here with us today, as well as a number of other sufferers, and it is my absolute privilege to stand in this place to speak for them and every other individual who is enduring this awful condition. At this point, I would ask the Minister if she would meet with me and Phoebe and representatives of other campaign groups to hear their stories of how they have been let down by the system. A chronic UTI isn't just a diagnosis. It is at present a life sentence of torture that eats away at every part of a person's existence. The condition first develops when bacteria from an acute UTI becomes permanently embedded in the lining of the bladder. Left untreated, the infection becomes entrenched, wreaking long-term havoc on the rest of the body. I want to be absolutely clear, chronic UTI should not be confused with a recurrent version of the condition. A patient diagnosed with a recurrent UTI may experience 1 or 2 infections over a 6-month period. Though still serious, patients suffering from a recurrent UTI experience distinctive intervals of relief from their symptoms. Chronic UTI sufferers live in constant and excruciating pain, with the infection never relenting. They are in agony every single day and every single night. Many sufferers have lived with the condition for decades, with the illness at present being incurable. Chronic urinary tract infections can affect anyone at any age. However, they disproportionately affect women. At the UK's only NHS specialist clinic, which I'll come on to later, 95% of patients are women, only 5% are men. Individuals living with a chronic UTI are often forced to urinate more than 20 times an hour. Each time they use the toilet, I've been told it feels like they are passing razor blades through their urethra. Their urine is bloody, their bladders are so tender they struggle to walk, and their bodies are consumed by fever. In many cases, the prolonged infection spreads from the bladder to the kidneys and the bloodstream, causing sepsis with other complications with other organs. I've been told of harrowing accounts of the agony caused by this illness. The pain has been likened to corrosive acid burning through the abdomen, glass shards lodged in the bladder, and the feeling of mice eating away at the sufferer's insides. Some liken it to scorching knives slashing forever at your stomach, or a hot cauldron constantly bubbling in your groin. But the most common comparison I hear people say is that their bodies are perpetually on fire. To reiterate, this torment never stops. For the majority of patients, it is 24/7. These symptoms destroy lives overnight. The illness renders individuals severely disabled, often forced to live a life of bed-bound isolation. The pain is so overwhelming that patients can lose their ability to sleep and become trapped in a cycle of exhaustion. Household chores become impossible, and individuals can lose the ability to care for their children. Sufferers often lose their dream careers as they cannot function with their symptoms in the workplace. They are unable to work or afford costly bills for private medicine. Young adults living with the condition often have to forego university studies, with the severity of their agony making their education unbearable. Romantic relationships break down, with at least one case, marriages of over 40 years ending due to the illness. Sexual intercourse is virtually impossible due to the immense pain. Many people with the condition fear they will never be able to start a family. Patients face an utter loss of independence. And unsurprisingly, depression and suicidal ideation are daily struggles for the chronic UTI patient community. This brings me on to my second ask for the Minister. Every healthcare professional in the UK properly must be briefed to recognise and treat a chronic UTI. Since 2022, the NHS website has formally recognised the existence of chronic UTIs, yet I've heard that many GPs and urologists still deny the existence of the illness. Patients suffering from chronic UTIs are left to fight for recognition, misdiagnosed with conditions like internal cystitis or recurrent UTIs.
Would the member give way?
Absolutely.
Thank you, Sir Desmond, for your chairmanship, and thank the member for giving way. Would the member agree with me that part of the issue with UTIs is the use of antibiotics, and that antibiotics are becoming immune to treating UTIs, and the medical profession can't keep up with treatments? And there's a case for better education within the general public in terms of sanitisation. And I know you can get UTIs from different ways, but certainly sanitation would be a helpful education reminder for the local population.
I thank the honourable member for his intervention, and he's absolutely right. Many of our modern medicine practices are designed around avoiding antibiotic resistance from building up, and the intention is to allow high-dose effective antibiotics to be available when required. Yet so many sufferers tell us that when they go to the doctor and require these high-dose effective antibiotics, they're then denied them. And if this is not one of the examples of where these effective antibiotics must be used, for which resistance must be avoided, there cannot be a better example of the mismatch between intention and practice. And I'll come on to it in more detail. But I thank the member for making the point there. None of the diagnoses fit, whether they are internal cystitis or recurrent UTIs, as is often misdiagnosed, and they therefore do not lead to effective treatment. And they compound the sufferer's agonising pain with awful frustration. At their most vulnerable and weak, they're being forced to try to prove what is happening to them is real. That is Kafkaesque. It is totally wrong. The key problem here appears to be that specific NICE guidelines do not exist for chronic UTIs in England, and that signed guidelines do not exist for the condition in Scotland. NICE guidelines for acute and recurrent UTIs exist, but as I've outlined, they are not fit for purpose for this chronic condition. How can GPs and urologists provide and recommend proper care as the first point of contact with the patient when there are no clear clinical guidelines in place? Without these, many medical professionals are practically blind to the condition. They cannot prescribe the right antibiotics to relieve patients' pain because chronic UTIs are not even on their radar. Chronic UTI specialists do exist, They do recognise the condition and they can help treat symptoms. But without proper guidance, patients are blocked by their GPs and urologists, unintentionally or not, from reaching them as their request for referral is refused. Many chronic UTI sufferers now have PTSD from their interactions with medical professionals, never mind the suffering from the condition itself. I've heard stories of patients being essentially gaslit by medical professionals, told the concern is all in their heads, denied antibiotics and given antidepressants instead. Some GPs and urologists have, it seems, dismissed the illness as a woman's problem and told patients just to deal with the pain. That is not medicine, that is misogyny. I therefore urge the Minister to push forward the creation of specific NICE and SIGN guidelines on the chronic UTI condition that are distinctive from recurrent UTIs. This is long overdue and will hopefully bring to an end these kinds of interactions between suffering patients and GPs. But that alone will not be enough. There have to be better treatment options for chronic UTI patients further down the pipeline too. Right now there is just one NHS specialist clinic in the entire country, the Lutz Clinic at Whittington Hospital in London. One clinic for a nationwide illness. The clinic offers fantastic support for patients, but waiting times are too long. We all know that waiting lists are currently far too high across the NHS, and I commend the government for their approach to bringing waiting lists down generally. But for chronic UTI sufferers forced effectively to compete for the time of one solitary clinic, this effect is even more pronounced. Sufferers are waiting months, even years for help after they're lucky enough to secure a referral in the first place. And even once they get there, hope of relief is still not guaranteed. The Lutz Clinic offers long-term, high-dose antibiotics that can treat the symptoms, but they only bring partial relief, leaving many dragging themselves through life, exhausted, drowsy and still in pain. It is not really living, it is enduring. And worse, they do not work for everyone. Around 30% of patients cannot tolerate them at all. Just imagine the despair of being in that 30%. It would be scandalous enough if it was simply that in desperation, many chronic UTI patients turn to private healthcare, spending thousands of pounds of money they don't have just to access the bare minimum of care. But it is more awful than that. Some are forced to go to even more extreme lengths, choosing risky, experimental procedures just to lessen their suffering. Flying abroad to unlicensed doctors, paying over £30,000 to have their bladders surgically removed. Let me say that again. People are choosing to have their organs ripped out in foreign countries because mainstream healthcare in the UK offers them nothing. For some, these risky surgeries offer relief. For many, the infection is already in their kidneys and they return from the operation bladderless with multiple complications. And it is with these little options left that some sufferers make a choice that should haunt this House, the most extreme choice of all, to take their own life rather than live another day like this. This isn't how people should be living in modern Britain, and that is why we should spare no expense in researching better treatments and, of course, as so many dream, a cure. I'd argue that government has an obligation, no matter the prevailing economic circumstances, to expedite the day that this is a reality. There are promising medical trials already underway in the UK showing real potential to transform how we treat chronic UTIs. These treatments are ready to progress to human trials. The only thing standing in the way is funding. I urge the Minister to look into the roadblocks to getting more funding to these trials and come forward at the earliest possible opportunity with a plan to put conditions that are underdiagnosed and under-prioritised, like chronic UTIs, at the front of their research agenda for this country's biomedical research industry. And I would be happy to put the Minister in touch with some of those who are working at the cutting edge of treatment in this field. I've told the story of chronic UTI sufferers and their longing for relief, a relief that this government can help them seek if they back their cause. But I'd like to remind this House that this exists in a much wider context. That is, the way in which health issues that mainly impact women are consistently neglected and routinely dismissed. We know that women wait longer in A&E. We also know that just 5% of global health research goes towards conditions that exclusively or disproportionately affect women. And despite the fact that 15 to 20% consult doctors for chronic pain, it was only this year that the Royal College of Obstetricians and Gynaecologists introduced an optional training module on chronic pain for trainee doctors. Inquiries like Patterson and Cumberledge have laid bare the systemic failures in how women's health is treated in this country, but implementation and cultural change has lagged far behind their words. I have wondered many things since I first heard the stories of chronic UTI sufferers, but nothing has unsettled me more than the lingering thought: if more men were affected by this disease, we would have had better treatments for this decades ago. And this is an oft-used cliche, but it comes up time and time again. I'm short on time, so I'll simply finish with this. The Minister has heard today about the scale of the unimaginable pain that those with chronic UTIs are experiencing. She's heard about the broken diagnostic system, which stops too many sufferers from getting the help they need. And she's heard about the roadblocks to developing better treatments that are standing in the way of relief. So I simply reiterate my asks. Will they meet with these brave sufferers and myself to hear more about the specific actions that government needs to take to clear these roadblocks? Will they commit to pushing for the NICE guidelines to be brought up to date to reflect the latest understanding of this disease? And will they outline what steps they are taking to combat the wider problem of the neglect of women's health issues? Colleagues, chronic UTI sufferers deserve so much more. Thank you.
Minister.
Thank you, Sir Desmond. It is an honour to serve under your chairship as ever. Thank you to the honourable gentleman, the member for Sutton and Cheam, for bringing this debate forward. And I'd like to welcome and acknowledge Phoebe and all the others in the gallery. And of course, I will put on record straight away that I will ensure that a meeting takes place with the relevant minister. We're just trying to work out, Sir Desmond, whether that would be me or whether it would be somebody else, but I will ensure that that takes place. I'd also like to recognise the contributions from other members here today. The Honourable Member for Dudley, who's no longer in her place, who always brings her own expertise as a clinician to this discussion and has done much to raise awareness. The member for North Down, who talked about antibiotics, who's also no longer in his place, and AMR, and I will come to that later, Sir Desmond. The Honourable Member for Strangford and the spokesperson for the Liberal Democrats spoke about Pharmacy First. And just to confirm that Pharmacy First does operate in England and it is designed to ensure that women between the ages of 16 and 64 can get treatment for uncomplicated UTIs. I think it is worth saying that the government currently has no plans to extend those that age group because we would not currently consider pre-16 and post-64 to be necessarily uncomplicated, and would argue that that would necessarily mean a little bit more focus. The Honourable Member for Watford recognised the desperation of many sufferers and highlighted the links to suicide. And before I come on to my speech and to refer to some other issues raised by the front bench spokespeople, could I say my honourable, and if I may say very good friend, the Honourable Member for Stoke-on-Trent South. She and I have been friends for some years, and I know how she suffers, and I recognise her courage, and she is such a powerful voice on this issue, and I'm delighted that she has done what was necessary and worked so hard to get to this place, to be that powerful voice on this issue, and I congratulate her on that. Yeah. UTIs, Mr Chair, are very common, especially for women, but chronic UTIs are much rarer. I say rare, but the charity Chronic Urinary Tract Infection Campaign, QTIC, estimates that up to 1.7 million women in the UK may suffer from a chronic UTI. This is a very large number of people living in discomfort, and I commend QTIC for their work in bringing attention to the plight of chronic UTI sufferers. I think it's really important that we make clear the distinction between a UTI, a recurrent UTI, and chronic or persistent UTI. A recurrent urinary tract infection is defined as having 2 or more UTIs within 6 months, or 3 or more UTIs within a year. Sometimes symptoms reappearing after a course of treatment. However, regular treatment can eventually cure these. For a chronic UTI, the symptoms never go away, despite treatment. At most, they might slightly abate. A UTI can impact significantly on someone's quality of life, making it hard to concentrate, sleep, or exercise. For someone with a chronic UTI, the pain and discomfort does not end. The physical and mental struggle is relentless. The contemplation of suicide is not uncommon, as we've discussed, amongst people suffering with chronic UTIs. And they can have a negative impact on both intimate and social relationships and self-esteem. This can be incredibly isolating. A population-based survey in England of women over 16 in 2015 found that 37% of women reported at least one episode of UTI in their lifetime. 29% of women reported more than one episode of UTI, and 3% of women reported a history of recurrent UTI in the past year. Misogyny in health services is an issue that has been discussed in this chamber before, and women's health remains a priority for the government. We've been let down for too long, but we are determined to change that, and women's health will continue to be a major focus as we fundamentally reform the health service and get it delivering for patients once again. We're working with NHS England to take forward our women's health strategy, and we have set out plans to use the independent sector to create to cut gynaecological waiting lists through our investment and reforms. And we will make sure that the NHS can be there for all women when they need it. And we are bringing through those commitments as part of our 10-year health plan. It is vital that people with chronic UTIs receive support and compassion from the NHS in diagnosis and treatment. No one suffering with a chronic UTI should be made to feel ashamed or in any way at fault for their condition. Living with the condition is a struggle enough without having to bear the insensitivity of others. Chronic UTI sufferers merit the same understanding as anyone else with a non-communicable disease. And as stated previously, why some people develop a chronic UTI is not well understood, and neither is how to cure one once it develops. A long-term dose of antibiotics has shown to work in some cases, but it's not consistently replicable and is not a risk-free approach. And then there are the added complications of antibiotic resistance to consider when adopting such a treatment regimen, and I will return to this point. Management of the condition is at the discretion of the responsible clinician based on their specialist training and experience. And patients who remain symptomatic despite investigations and treatment by specialist urological services can be referred onwards to tertiary services. Again, it must be emphasised that all patients with chronic UTIs should be afforded compassion and support as part of their care. And as the Honourable Member that has brought this debate has said, there is no NICE guidance specifically on chronic UTIs. The existing guidance provides advice on pain management and hydration, and the local NHS is expected to have regard to NICE guidance in providing care and advice to patients. HSA, the UK Health Security Agency, has begun work in this area, working alongside NHSE England, primary care and patients to develop resources to support clinicians in managing UTI conditions. At the moment, this is for recurrent UTIs, and we agree that more research is needed. To address this uncertainty, research is being undertaken. Through our National Institute for Health and Care Research, we're supporting work to understand the research gaps on UTIs. This is through a James Linda Lyons priority setting partnership led by Antibiotic Research UK, Bladder Health UK and the Urology Foundation. And this partnership will publish its findings in spring 2026. The department, through the National Institute for Health and Care Research, is funding research to improve the diagnosis and treatment of urinary tract infections, including chronic UTIs. And this research includes development of antimicrobial impregnated catheters to reduce episodes of catheter-associated UTIs, as well as something called the Toucan study, evaluating the rapid point-of-care UTI diagnostic tests in GP surgeries. And recently, the NIHR invested £3.1 million into improving primary care antibiotic prescribing programmes. I want to return to the matter of antimicrobial resistance and why this is an important consideration. The first 5-year National Action Plan for AMR in 2019 set out a comprehensive One Health approach to address AMR, acting across humans, animals, food and the environment. And a further 5-year plan was published in March 2024. The UK Health Security Agency has also been working with colleagues from NHSE, primary care settings and patients to develop resources supporting clinicians through the Target Antibiotics Toolkit. This toolkit training is currently being rolled out in multiple NHSE regions as part of an intervention to improve the management of common infections, including UTIs, in primary care. We need to build on these successes and ensure that antibiotics use is supported by evidence. AMR is a significant health threat, and there are an estimated 7,600 deaths attributable to AMR in the UK in 2019. Sir Desmond, the Lib Dem spokesperson also spoke about dementia and the added complications that this can lead to. Diagnosing UTI can be especially difficult in older people who often present with atypical or non-specific presentations, and it can be difficult to assess lower urinary tract symptoms in older patients due to dementia. In care home settings, the resident may not initially present as acutely unwell. This may include increased lethargy, diminished appetite, reluctance to drink, or just not being their usual self. And there is a tool such as Restore 2, which can support care homes to alert them in a primary care, to alert a primary care clinician that the resident may be unwell and would benefit from an early clinical review. Care home staff encourage residents to keep hydrated. All this can be challenging in residents with dementia, as we know. But the department is funding research into dementia and chronic urinary tract infections via the National Institute for Health and Care Research. The Stop UTI project at the NIHR's Applied Research Collaboration, Wessex, sought to identify effective strategies for preventing and recognising UTIs in care homes, and has done some work on embedding activities into care routines and concluded that a systems-wide approach was necessary. In July 2024, the NIHR published a call for research applications to improve diagnosis of UTIs in older adults, and Stage 2 applications are being considered by the funding committee this month. The Honourable Member, the Lib Dem spokesperson, also talked about, let me get my notes, I've been running around making sure that I try to catch everything, about community pharmacy, the 10-year plan, which will of course cover all conditions and is a strategic overview of how we'll improve the NHS for everybody. And I can confirm that the 10-year health plan is on track to be published next month. The shadow spokesperson talked about research, programmes and guidance, and I think I've referred to most of those things in my speech. If I have not, then I'm more than happy to write to the Honourable Member, the Shadow Minister, after this debate. But she did also touch upon prevention, and the UK HSA is working with NHS England to run a targeted campaign around UTI prevention in older adults. This campaign will include messages and materials that can be used to support older adults to adapt behaviours that should reduce the risk of developing a UTI, including messages to suggest talking to clinicians about treatment options if they have recurring UTIs. But in conclusion, Sir Desmond, I want to highlight our work to make a health service fit the future. We hope our focus on the 3 shifts to develop a modern NHS will help to address many of the challenges in navigating the health service with those, for those with long-term conditions, including chronic UTIs. Our shift from hospital to community will help drive more joint working between neighbourhoods in primary care, pharmacies, community health and social care to help people manage their conditions. We will, as I've said, shortly be publishing our 10-year plan for health, which will set out how we will make our NHS fit for the future. I want to thank the honourable gentleman once again for bringing this debate forward to raise awareness of this important but often overlooked issue. Thank you.
Luke Taylor to sum up.
Thank you, Sir Desmond. I'd just like to start by thanking the honourable member for Dudley for her contribution on the broader health inequalities for women and offer her my best of luck to securing the debate that she seeks. I'd thank the honourable member for Strangford for his contribution about particularly the strain on NHS resources that the lack of attention on the condition creates, further compounding the challenges and backlogs we have in the system. Thank the honourable member for Watford for his account of the impact on his constituents who had to give up her job and the terrible impact that it has on private lives. Thank my honourable friend, the member for Chichester, particularly talking about the challenges around the issues with the antibiotic regime and the issues with resistance and the complexity with that issue. I do thank the contribution from the honourable member for Sleaford and North Hykeham. Particularly, I think, instructive was the focus on treatment of children, because as we heard, the challenge in stopping a UTI becoming a recurrent UTI, which becomes a chronic UTI, is a real focus for that. And again, the focus on pharmacy first to stop that and how children can be addressed to stop that from becoming an issue in the first place, I think was a particularly insightful point. And again, thank her for giving her a knowledge as a doctor to the debate. I thank the Minister for her confirmation of a meeting with myself and with campaigners to discuss the issues. I do note I didn't think there was a specific answer on how nice and signed guidance would be updated to incorporate, but we can speak on that later, and I apologise if I've missed that. I think I'd really like to focus, however, on the contribution from the member for Stoke-on-Trent South, who spoke so heartbreakingly about her experience of the condition and about how it has driven her into politics. And I really do look forward to working together to try and raise this issue and keep it current and understand how we can help her and the incredibly brave campaigners who brought the case to my attention and really see some action with all of the various streams of action that we can put forward in this place. So again, I thank the Minister for being here to listen to the stories of sufferers and responding to my points. I thank all of the honourable members for taking part in this debate, again, and particularly to the honourable member for Stoke-on-Trent, again, for her bravery. I thank, as well, campaigners like Phoebe here in the gallery, whose strength and resilience has given us a chance in this place to try to take clear actions to give them their hope back. Thank you.
The question is that this House has considered chronic urinary tract infections. As many as are of that opinion say aye. Aye. Of the contrary, no. I think the ayes have it, the ayes have it. Order, order. The sitting is suspended until 11 o'clock or until all the participants in the next debate are here, if earlier. Thank you very much.